Uh, we all are good in performing a microlumbar discectomy, though we have been trained to do it through the interlaminar approach. Let us go through the history of interlaminar discectomy. The first operation through this route, through the midline approach, was done by Mixter and Barr in 1932, and the extradural approach was described by Dr. Lau in 1938. What we are following now is the modification of what Dr. Lau introduced in 1938. After the introduction of microscope by Dr. Neurosurgeon in 1967, it was further refined, and at the same time, Casper devised his own techniques. So what I want you to see here is all those red color, highlighted, all those are neurosurgeons. So the neurosurgeons did have a good contribution for interlaminar approach. Maybe because we neurosurgeons, we deal with brain and spinal cord, and we want to see what we are cutting. So neurosurgeons got involved from the beginning in interlaminar approach. Here, can you distinguish between which is microlumbar discectomy and which is endoscopic discectomy? The left one is microscopic discectomy and the right one is endoscopic discectomy. That is 2 centimeters in size and this is 1 centimeter in size, not a big difference. So my talk today is not to tell you about the size of the incision or the muscle dissection alone. It is something different. It is something completely different concept of approaching the disc through a different corridor. Dr. Parthiban did mention about that transforaminal approach, and that's what I'm going to talk today. So the endoscopic spinal surgery has been in the vogue. What is the big deal? Dastandu has introduced lots of endoscopic techniques. Lots of tubular retractors are in the market. So what is the big difference? All these techniques have been, dealing only with the interlaminar approach. We all know we go through the interlaminar route, we split the muscles, and we reach the ligamentum flavum, just split it open, enter the epidural space, retract the nerve root, and reach the disc. But what I'm going to talk today is a forolateral approach where we do not disturb all these normal structures. We are going to come from a far-away route, from a lateral route to reach the disc to the foramen or extraforaminal in case of extraforaminal disc. Who is a better spinal surgeon, neurosurgeon or orthopedic surgeon? This contest has been going on, but for the transforaminal route, the contribution was mainly done by the orthopedic surgeon. Maybe because, as I already told you, the neurosurgeons, we want to see and cut, but the orthopedic surgeons have pioneered this technique. They introduced a needle through the from the forolateral route into the nucleus pulposus, from which they gradually innovated various techniques, and finally they are quite successful recently. Of all these names, I want you to concentrate on Parvez Kambin, who has developed this technique and also defined the anatomical landmark for safe entry zone. In those days, the surgeons who make big incisions were called bigger surgeons. And later it changed to the surgeons who made smaller incisions were called bigger surgeons. But particularly the transforaminal route started from a small needle, and from which they innovated quite a few technology to get where we are today. So he is Professor Kambin, and he devised this triangle for safe entry of the needle. You can see the hypotenuse is formed by the exiting nerve root, and the base is formed by the upper end plate of the lower vertebra, and the height is formed by the traversing nerve root or dura. Usually that is masked by the ascending facet. So this is the safest entry zone. So you have to go away from the hypotenuse to reach the safest entry zone into the nucleus pulposus. As Dr. Parthibin mentioned, everything started with the nerve root blocks and also from nucleoplasty. So this is a percutaneous technique where the needle is passed through the Kambin's triangle. See, it is going just above the lower
longer, maybe therefore a little bit softer. I mean, what would be your
and it is entering into the nucleus pulposus. And the last picture shows the contrast being delivered into the epidural space through the foramen. So from the needle, quite a few innovations have been made. The endoscopes are made with a wider working channel. The bevel-ended tubular access cannula is an innovation. The bevel end helps to retract the nerve roots, and the total width of the cannula is around 8 millimeter only. And the endoscopes are having multiple channels, wide angle lens, high definition cameras, various drills and trephines, variable tip angle and articulated instruments. They've all made the surgery quite successful. And the last one, the radio frequency ablator, is quite a nice one to do. There is no need to use bipolar. We can use this radio frequency ablator to cauterize. I will show it in my video. So this is, can you see my video? Yeah. So this is our operative room organization. The C-arm should be on the other side of the side of interest. Here we are operating on the right side. So we are using reverse spine. The monitor should be on the opposite side. So instrument port, light source, and irrigation port are all seen. Here I want you to concentrate on these two lines, the posterior facetal joint line and the interspinous line. The interspinous line is the tip of the spinous process, and posterior facetal line is along the posterior part of the spine, the facets. So if you go enter anterior to the posterior facetal line, there is a risk of entering into the pectoral cavity and also a risk of injuring the kidneys. So you have to go behind the posterior facetal line. And in the AP view also, you have to concentrate on squaring the end plates. Here the end plates are squared, and then only the needle is advanced. So you can clearly see the posterior facetal line and the interspinous line. This is the posterior facetal line. So the needle is in, and now the K wire is passed. So we are within the nucleus pulposus. This has to be done in AP position only. Now the cannula is, the trocar is passed first. Once the trocar reaches the nucleus pulposus, which is advanced in the AP view, the cannula is passed. From the far lateral approach. I understand the midline is far away. I want you to understand that midline is far away. We are coming from the far lateral route. Once the cannula is in, the trocar is withdrawn. And now we are seeing the endoscopic view. So we are within the nucleus pulposus now. So in this technique, we are reaching the pathology first. We are not at all dealing with the normal structures like the nerve roots or the epidural fat. We are dealing with the pathology first. And toward the end, we will see the the posterior longitudinal ligament and the rent in the posterior longitudinal ligament. And finally, we will see the epidural space and the nerve root. So this is the radio frequency ablator I was mentioning. I think you have started to see the PLL now. The epidural fat is seen now. So this is the scissor which cuts the posterior longitudinal ligament. So at the end, you are seeing the nerve root free of compression. So what are the advantages of this transforaminal discectomy? This route is transmuscular. In result, epidural and neural veins are protected. The epidural scar tissue is prevented as there is no handling of the neural structures or the epidural vessels. There is no or minimal bone removal. The connective tissues and ligaments such as ligamentum flavum and PLL are protected. The paravertebral muscle retraction is not performed in this approach. And as a whole, the supportive and connective tissues are preserved in posterolateral approach, and so the risk of disc herniation recurrence is less than the middle approach. In case of recurrent disc herniation, middle approach is fresh if you contemplate redo surgery. But this technique is not without complications. The minor complications are transient dysesthesia, hyperesthesia along the nerve root handle, infection and hematoma formation, they are quite rare. Dural tear and late recurrence can happen. Major complications like injury to the exiting nerve root, cauda equina injury, major vessel injury, injury to the abdominal viscera, mainly the kidney, and increased ICP due to the pressure exerted by the irrigating saline have all been reported. What are the limitations of this technique? There is a steep learning curve. Mastering the endoscopic anatomy and techniques is mandatory. The instruments are quite long. They are around more than 25 centimeter in length. So they are quite long. So they may break while you handle it for the first time. So you have to be very careful when you use it. The iliac crest, when it is high, we cannot approach that through this approach, forlateral approach usually, because it is on the way. So you have to adopt for interlaminar approach. Migrated disc, what do you do? Sometimes, with the experience, we have started doing migrated disc with this technique, but for the beginners, it may be difficult. As a whole, there is a quite steep learning curve. So the final question, transformation from microlumbar discectomy to the endoscopic discectomy, is it worth the hard work? And my answer is yes. Thank you. I would like to thank you, Dr. Divya, and the organizers for giving me this fantastic opportunity to talk in this forum. Thank you.
Thank you, Vijay sir, for the wonderful talk and telling us about the evolution of a needle to an endoscope. And it was a nice talk. So thank you so much for being present here. And with this, Dr. Anil, yeah, please.
I have a quick question to Dr. Vijay. Dr. Vijay, which company endoscope do you use?
Reverse spine, Richard Wolf.
Which one? I'm sorry?
Richard Wolf.
Okay, thank you so much.
Yeah.